Hello and welcome back to Wheel Chat. Wheel Chat.
It's on. I love how much gusto you come in on the morning, mate. It's like the break of dawn where you are, and you're just like, I'm ready to go. So excited for today. So this is, we have Rubén Serrano. Tell me, Rubén, about your Instagram page. What's Rubén Serrano _TO, which is that OT backwards? What's TO?
Yeah, TO is terapeuta ocupacional. That it would be the same that OT, occupational therapist.
It sounds so much sexier, doesn't it?
Actually, I started this Instagram account when I started to see that there was a lot of content of sitting, but not always saying right things.
So tell me about it. With you specifically, or maybe you'd be better explain to everybody what to you is the mat assessment in terms of the physical assessment.
Well, actually, I think one of the most difficult things in our industry is to make some decisions, no?
I'm sure most of the time you can make it work, but there are times where you have to be honest and say, no. Hello and welcome back to Wheel Chat. Wheel Chat. Good afternoon, good morning, good evening, wherever we're coming to you from. I am Anton, and this is
Wheel Chat.
Boulos.
Anton, I love how much gusto you come in on the morning, mate. It's like the break of dawn where you are, and you're just like, I'm ready to go. So excited for today.
Thanks, Justin, but I'm going to have to be honest with the listeners. I have slept in, guys. It is 6 a.m. in the morning here. Well, it's now 6:30. Our most fabulous, wonderful, understanding guest, who Justin is going to introduce in a moment, has been extremely understanding. I don't know if it's been a good thing or a bad thing for him that he's had to chat to you for half an hour to kill time, but no, I'm only joking. It's been thank you, guys, and apologies, listeners, although it hasn't affected you guys. I am now alive and well and enjoying. So without further ado, Justin, can you introduce our most amazing guest?
I would, yeah, it would be my honor. So this is, we have Rubén Serrano. Is that how you say it, Rubén?
Yes, Serrano. It sounds in the Spanish, but it's okay.
Rubén Serrano, who's an occupational therapist and a clinical educator on seating and mobility, who's been doing it for about 15 years. Really knowledgeable guy. I first stumbled upon him on Instagram, seeing him post a bunch of content about wheelchairs and seating, but it is all in Spanish. So I can't appreciate it, but it looks like he's talking about some dope stuff. So I cannot wait to hear what it actually means in English. So I brought him onto the podcast. Rubén, good morning to you.
Good morning. Thank you. Thank you, both of you, for the invitation. Thank you for the advice. Maybe I need to start to add subtitles in English. Because I think if I start to do it in English, speaking myself in English, probably I'm going to lose all my followers. But maybe...
So
do it in English.
Yeah, do it in English. Tell me, Rubén, about your Instagram page, and we'll put it in the show notes as well. It's Rubén Serrano _TO, which is that OT backwards? What's TO?
Yeah, TO is terapeuta ocupacional. That it would be the same that OT, occupational therapist. But in Spanish, you know, the adjectives is going after the name, no?
It sounds so much sexier, doesn't it? I
Yeah.
think, you know,
The way you said it.
yeah. Yeah. What do you do? I'm an occupational therapist. What do you do? I'm a
occupational. No, therapy. I can't remember what you just said.
I don't even know what you
good.
said, Rubén, but it sounded amazing. No, I'm only joking.
The good thing in my family, my sister is OT too, and my father is called Theo. Theo, it's like Theo, no?
Yeah,
So
yeah.
I can say that in my family we are all TO, no? Because in Spanish, Theo, it sounds like Theo.
Yeah.
So, well, even my father is Theo. So that we are a Theo family.
I love that. I love that.
It's a joke, but it's okay.
No, I like it.
It's fine.
Yeah.
I've got to ask this start off. What made you first start posting about wheelchairs and seating? Because it's on like your own certain thing. So it's not necessarily a part of an organization you're with. It's just, is this just your regular Instagram profile, or is this like a separate business one as well?
Well, actually, I started this Instagram account when I started to see that there was a lot of content of sitting, but not always saying right things. So even I would say if you look at my Instagram account, it's like very. I try to take care a lot of the evidence behind of that, of the justification, or I don't know, trying to explain what's behind or the science behind of sitting, and that was the aim. It's totally personal. Actually, I try not to talk about brands. Obviously, is very difficult not mixing with some brands, because you know that the products are related sometimes with the features of some products and what you can do with some of them. But I think it was important not to talk about products, even more if you consider that I'm working in distribution. And when I visit all the places trying to recommend something, oh, okay, you are recommending me this because you are from this brand, no?
Yeah.
So for that reason, it's quite difficult to find a lot of posts talking about specific products. I try to talk about the science of sitting behind those products, no, not the product, actually.
We got
Sorry,
things like
Justin.
Christopher Xavier over here as well. We've got the doll, the figurines, like the ones behind you.
Well, if you can see, I have a lot of dolls like that. And I
I
have two
think,
hammies, but now I have rib cage.
yeah. Now the Hammy now has the rib cage as well for 24-hour positioning, doesn't he?
Yeah, exactly.
So for those who don't know who aren't watching at the moment, I'm just going through Ruben's Instagram page, and he's going through a product which is called the Hammy, which is a really good tool for educating people on how the body works. It's basically like a little figurine that has ropes and things attached to it. When you pull on one, you see something else move. For example, like your hamstring, if you extend the knee, it may pull onto the hips and rotate the hips depending on how long you have the string or how flexible the person may be, which is it's a really cool tool. I want to get one. I'll get one day. So Ruben, on your page that I'm currently giving you a big stalk at the moment, I see you doing a lot of stuff on the physical assessment. Is this I can't see what it says in Spanish, but it looks like you're teaching people how to do what we call the mechanical assessment tool, which is the mat evaluation, specifically with the physical side. So tell me about it. With you specifically, or maybe you'd be better explain to everybody what to you is the mat assessment in terms of the physical assessment. What is it, and when do you do it, and why do you do it in general?
Well, actually, I think one of the most difficult things in our industry is to make some decisions, no? Because what's the reason why we decide to put one cushion or another? What's the reason we decide to put this trunk lateral or in this position or in this other one? I think, I don't know, I'm going to talk about my experience in Spain mainly, but I think it's something that happens worldwide. And actually, I think that generally we are based in our good side. So it's like if I have an X-ray vision and I'm able to decide everything just saying, oh, this shoulder is higher than the other one. Oh, it looks like this hip has like a pelvic obliquity. Oh, this looks like he can correct this scoliosis. And everything is like an act of faith, no? And I don't like, well, I'm sorry because what I'm going to say, but I'm not a faith man. I'm a science man. So that's the reason I started to do math assessment. Actually, I don't know too many people in Spain who do or who practice with math assessment. Actually, I always call it math assessment because we don't have any word for that in Spain, or I think so. Maybe someone can correct me after listening this podcast. And one of the main reason because I do this assessment, or I try to do, I would say in the 95% of the, well, I have to say, first of all, I have to say that when I visit a center, they show me their most difficult case. So normally I need to do a math assessment. No? When they call me, it's because they don't know what to do with that user. No, I'm sure you know this feeling. So I
Sorry,
always
Ruben.
need.
We are called the problem solvers. That's what we're here for.
Yeah.
Yeah.
That's yeah. It's interesting because you are in a position that someone calls you from a rehabilitation center or whatever, and you say, okay, let's see if I can get their trust, their confidence, no, and do a
Course.
good work. And always they put you in front of you the most difficult child they have, the most difficult user they
Yeah.
have,
Yeah.
and you say, okay, let's try. No,
Yeah. I know exactly how it is, and sometimes it's. I'm sure most of the time you can make it work, but there are times where you have to be honest and say no.
exactly.
Yeah.
The most important thing
Yeah.
is to be honest,
Yeah.
and you are there to try to help. Sometimes you can do something very good and it's challenging. Sometimes you can help and it doesn't matter. It matters, but it's not important because you have done what
Sure.
you needed to do. No, so well, that's the reason I do math assessment because I didn't want it to do something because I think is the best thing. I wanted to do something because I have assessed,
Mhm.
and if I consider that biomechanics, this is the best thing that we could do with this user. For that reason, I think that math assessment is important, but it's even more important if you can understand biomechanics. No, I don't know. When I do my courses of math assessment, for example, I spend like 3 hours or 2 or 3 hours talking about anatomy and biomechanics.
Mhm.
And why? Because I think obviously math assessment. Well, I'm going to I'm trying to explain what's math assessment first, if you want. Math assessment is an assessment that you do in a math. It's easy as that till here. Eh, And obviously, what you want to consider is what are the range of motions of some of that joints that are going to be involved in sitting, like the knee, like the hips, like the trunk, like the neck. What's the range of motions without compensations that user can reach without the gravity affecting him or affecting them? So, and once you have analyzed all that movements, you can do it in sitting and try to make some decisions to transfer that to the sitting unit. No, what I always say is that that's very important when you can understand anatomy and you can understand biomechanics. Why? Because I don't know. I'm going to try to put an easy example, but it's a technical example. I don't know. If we think about hamstrings, for example, I think it's the typical case. We understand that it's a, I don't know if I'm going to say it well in English, but it's a biarticular joint or biarticular muscle. So it's through two joints, no, through the hips and through the knee, and obviously their origin is in the IT, in the buttocks, and their insertion. I don't know if that's the right word in English.
Yeah.
And it ended in the tibia. I don't know. It's the same
Yeah.
in
That's right. The
English.
tibia
Yeah.
is correct, and behind the back of the knee for listeners.
Okay.
Yes. Yeah.
Exactly. So two movements are going to be related with that tension or with that tightening of the muscle. No,
Yeah.
if you move the flexion or extension of the hip, or if you move the extension or the flexion of the knee, it's going to be involved in how tighten it is that muscle. And if that muscle is too tighten it's going to pull from the buttocks to the front, and probably you are going to get some posterior tilt. So it would be more than interesting to understand that, and probably, for example, I love to analyze the muscles in different planes. Actually, I don't know if you can see, but I have some planes here from yesterday. I was doing a publication in my Instagram. And well, when you analyze, for example, the hamstrings muscle in different planes, you can analyze or you can realize that hamstrings are extensors of the hip. They create also posterior tilt in a sagittal plane, but also when you talk in a transversal plane, if you looking from the top, you are going to get internal rotation, or the hamstrings is going to make internal rotation. And also, if you look it in the frontal view, you are going to get adduction. So it's quite interesting because a lot of the users that you can assess with tightened hamstrings are also with internal rotation and adduction. So it's like, wow, it's interesting. All these things are happening together normally, and all the things are related with the anatomy and the biomechanics, no? So how important is to assess this to decide how are you going to sit this user, no? So it's just one example, but I think it's a clear example to understand why it's important to assess that in order to, because obviously we have some objectives, no? When we decide to make a sitting with one user, our objective is to avoid, I don't know, hip luxation, or to improve breathing, or to improve the function of the user in the wheelchair, or to make the user to drive their wheelchair independently. You have an objective. So if you want to get some of those objectives, you need to assess in order to decide what's going to be the best for that user in that case. For example, for me, hip luxation is quite important. It's something to avoid, because I don't know if you look at the evidence, at the research, it looks like that probably hip luxation is the first step. After the hip luxation appears pelvic obliquity, and after pelvic obliquity is going to appear scoliosis. So probably if you know that the path is going to be like this one, maybe it's good to find something to stop the first step, no, or trying to delay that step as much as you can, no.
No,
And
this
then,
is true.
yeah, and then how do you do that? So you mentioned that when you said the first step is hip subluxation, and so the leg coming out of your hip joint, and then that leads to pelvic obliquity, so one hip height being higher than the other. What's causing that hip subluxation in the first place? Is that through growth? Are you talking about with children when they're young, they're getting hip subluxations, or is this happen to adults who maybe start using a wheelchair in their 30s? How does one get hip subluxation just from sitting down?
Well, I love that you made me this question, and it's a very, very interesting question, because I think, well, sorry, because probably I'm going to start to talk some technical things, but I will try to explain it correctly.
Explain it like a
properly.
2 or 5-year-old. I'm 5 years old, and you say there is a human body. Now
I don't know how to say. I don't know how to say the neck of the femur. No. Well, it's a very important question, because I think it's very important that we consider this even from the birth. What I mean is, when we were born, our femur, it's with another neck or femoral head angle. So we have something that technically is called a valgus. I don't know what. The angle of the head of the femur with the bone of the femur, it's like 135 degrees. The problem of this is that if you have a picture of a valgus coxa, that would be great. No, that doesn't matter. Well, the thing is that when we were born, we have an open angle of this hip and of this femoral head. And we need to weight bearing to make that head to get down. Why is this important? Because if this femoral head doesn't go down, the risk of hip luxation is going to be bigger for several reasons. Because biomechanically, if I don't know if someone is going to see me, but if you imagine this hand is my acetabulum, and this is my femoral head. When I go to abduction, my femoral head is going out from the acetabulum. Despite of that, or however, if I do abduction, obviously the femoral head is going to push harder against the acetabulum. The acetabulum and the femoral head, the development of the acetabulum and the femoral head is codependent. So that it means that they help together to create their form or their shape. So for that reason, I think it's important that even if the development of the child is not the normal one or the regular one, you need to do standing, and if it's possible with abduction, because you need to make that round acetabulum as much as you can, and you try to make that femoral head as round as much as you can. And abduction is going to help you for that, and that weight bearing is going to help you not just with this mineral density, also is going to help you with trying to bring that head down and to improve that angle between the bone and the femoral head. And this is very, very important, because when you analyze the biomechanics of a femoral head, for example, we know that mid-glute is right?
That's great.
Mid-glute is a muscle from our butt. It's the main abductor. It's the main muscle abductor, probably. If you try to, well, it's difficult to explain a 5 years old the moment arm of a muscle. But if you consider that this moment arm is the most important thing in terms of torque or maximum force created by a muscle, when you have the kind of angle of when we were born in the femoral head, it's much easier that the adductors muscles have more mechanical advantage to make a strength than abductors. So that's one of the reasons why biomechanically it's even important to consider this in order to avoid hip luxation or subluxation. So I would say abduction is important, mainly in standing. Well, sometimes I try to do some jokes when I giving classes to my students, or when I am invited to universities to give some class, and I say, well, sometimes we think that our users are Jean-Claude Van Damme, but yeah, this is the reason. Anton have understood me, and I don't know if Justin knows who is Jean-Claude Van Damme, because he's younger. So nowadays, people doesn't understand me when I'm in this, but I think Anton has understand me perfectly.
He can do the splits.
Blood sport. It's great.
Yeah,
It's one of the best movements. Yeah. I mean,
he's the king of abduction.
Exactly.
So just to clarify everything you're saying for everyone listening. So if you've got someone with a congenital condition, meaning that they're born with it and they're born without the ability to walk or to weight bear through their legs, standing is really, really important so that the hip joint develops properly. If we're born seated and we're constantly spending time in seated, we're going to get hip subluxations. Do you see that happening in populations outside of kids born with a condition, or is it only with those who have always been seated?
Well, actually, I think it's more related with not walking exactly, because, for example, I have tried to look for research in spinal cord injury, and it also appears hip subluxation or hip luxation in spinal cord injury in children with a spinal cord injury, but they appear more as younger they get the injury, and as I would say the risk increase as sooner they get the injury. So actually, I would say, or I would dare to say, that it's related with the development. So it's difficult if you have a spinal cord injury with 50 years, and well, obviously you can have it probably, but I think it's going to be more difficult.
So it's more about age rather than the actual condition. So just because you got cerebral palsy or something, it's not necessarily about that. It's more the fact that you're young and you haven't had the chance to develop properly. In that case, okay, so that makes sense. So that means that look, stand-in is important, and we could probably do a whole topic on stand-in. What does that mean for seating, though? Do we need to be abducted when we're seating? Like, should we be sitting all kids? You know, say if there's any kids under 10 years old, should we be sitting all of them in abduction?
Well,
if they are not walking.
Yeah, I think it's an interesting topic too, because, well, abduction is important, and when you read some hip surveillance guidelines or whatever, they tell you that you need to keep that abduction in standing and sitting. But I think that sometimes we misunderstood abduction with Jean-Claude Van Damme, no?
Sorry, what was that?
No, sorry, I was meaning that we misunderstood that when is abduction and when is too much abduction.
Yeah, Jean-Claude Van Damme.
Yeah, Jean-Claude Van Damme, exactly. And that's right, no? Because even if we consider the wheelchair that we are going to use, it's very difficult to mount some sitting unit with a lot of abduction in a wheelchair, no? I don't know if you have, I don't know. I've seen some people that they want to create 60 degrees of abduction in sitting. And maybe you have a hip width of, I don't know, 30 centimeters, and you need a 40 centimeters wheelchair or even more. And what happened with the other things? What kind of backrest are you going to mount where the laterals make the force when they have to be done? And what happened with the armrest? It's going to be very far, and you're going to create an abduction in the shoulder that maybe is going to create some difficulties to make things in the midline. So we need to think in global, no? And obviously it's important to avoid the abduction in sitting, because obviously you will be helping to make this head to get out of the acetabulum. But obviously we are doing 2 hours per day of standing, and we have a good abduction or a fair abduction in sitting, and we try to avoid. But I don't know, for example, I don't know if you know this research, but for me it's quite interesting because I don't like pommels. I don't like pommels, sorry. And
why is
there's
that?
a research. Well, I think because pommel in Spain is called abductor block.
Yeah.
And I wouldn't say it's an abductor. I would say it's AB.
Yeah. So it's called an abductor block.
Yeah, that would be like the translation, the direct translation. Taco abductor. That would be what we call in Spanish. And
it sounds like that means, like, that translation is there is a block that is causing abduction, whereas it could be misunderstood as block as in like defense, you know, like I'm blocking something from happening.
Well, like a pommel, we are going to call it.
Yeah, exactly. Okay? Yeah. But
sorry,
I think there could be room for. I think there could be room for misunderstanding, because, like, we might say like a hip block might be something to like block your hips from moving, you know, like because it's blocking it. But then it could also just be like a block, as in like a brick, like something is a block, is an object.
Exactly.
But it sounds like
for me that would be an abduction block, not an abduction pommel or an abductor pommel. And it could be something stupid, but I think it's important because it's not getting abduction and it's blocking the abduction, but it's not blocking the internal rotation. So if we are talking that when we have analyzed the hamstrings and other muscles, we have children with abduction, internal rotation, why are we are just controlling adduction? Actually, when we try to get some external rotation, some of those adduction disappears, no? Because it's like easier to get them to abduction when you get them a little bit of external rotation. Because probably external rotators and abductors are synergist as adductors and internal rotators. And it's quite common to see pictures of people with the pommel, and obviously they have their legs separated, but they are in internal rotation.
Can I interject just for 1 minute?
Yeah.
Because I think that's really important, and I think what you're saying is 100% true, and we know this. You've seen it many times. We've all seen it many times. I'm sure the listeners have as well. One of the things that I just wanted to sort of move on, but within the same conversation, is over time a subluxed hip can also be lead to dislocation. Over time, we see a lot of people with dislocation, okay? And therefore, we don't, and not just with dislocation, but we do need to go with the external rotation, internal rotation. We don't want to always abduct. We want to adduct. We want to, in essence, the presentation we're talking about is wind sweeping. So where the hips are going one way or the other, and we don't always want to fight against this. Everybody wants to make somebody look straight, right? And you're nodding your head, and I'm sure Justin agrees as well. And what that does is when you try to make somebody look straight, right? So you want to move the hips into midline, you want everything to be in one. This actually is a negative for most of the clients of the presentation we're talking about, right? And I'm interested to know your take, Rubén, how you manage that. Are you happy to accept that what I'm saying is correct in some times and quite a lot with the customers, users that we're talking about? Or is there a different way of approaching that? Because I'm just interested in your opinion.
Well, I think you are 100% right. And that's one of the reasons we need to do math assessment. Because when I do math assessment, I can assess what's the abduction of that hip. And I love to do math assessment in these cases because when you move the hip to abduction, you can see how the opposite pelvic side, it's going after you, no? It's going with you. When you look that, what do you prefer? To have your legs looking at the front, or you want to have your hips or your pelvic looking at the front, avoiding to rotate the spinal, the spine, no?
Yeah.
In my opinion, obviously, I want to keep the spine and the pelvic and the pelvis in the right position because obviously inside or related with my pelvis and the spine is going to be a lot of organs who are related with my surviving, which I think is one of the main objectives of us as professionals, is to keep our users alive. No, this is one of my main objectives every day. So you're right, because sometimes we put the block and the legs looks right, but you are creating a rotation in the pelvis, and after that it's going to follow the spine. So for that reason, it's very important to make a math assessment, for example, because you are going to discover if that movement is reducible or non-reducible. And if it's not reducible, until which position I can do it. Because how I take or how I make this decision if I don't know what's going to be the range or the right range or the right range without compensation or the right range without pushing other body segment follow the other one. What would be that range if I can't assess it and I can measure it?
Mhm.
Even maybe if you are very experienced, maybe you don't need even measure it, but you need to assess it, because I think sometimes clothes can lie to you. Sometimes users looks like very happy with some kind of things, and they are able to distract you from the thing, no? So yeah, that's important. And when I was talking actually about the research, is that there is a research that talk about medial thigh support, which would be this pommel, with gross motor 4 and 5 in cerebral palsy, spastic cerebral palsy, and they realize that with the pommel they get more hip subluxation than without the pommel. And it makes sense, because if you have your adductors pulling harder from your bone, probably the pommel is going to be your fulcrum,
Yeah.
and the head is going to be out. It's going to get out. So for that reason, I think biomechanics is essential in sitting and posture.
It's very
Or I read.
interesting, Ruben. I love this conversation. I'm really, this is my passion myself personally. So, you know, I could talk for hours. Um, but I think what I'm taking from what you're saying is that there is a need for abduction or adduction, depending on the user's needs at that specific time. But the way of managing that, you are not so keen in putting such a big pommel in. So a solid block, if we want to call it that, that abducts. So that separates. So just for the users, abduction is where we are separating the knees in this particular conversation, where we're opening up that area. And adduction is controlling the knees from to close them, to bring them closer together, right? So we use a lot of contoured seat cushions, myself personally. So things that have an abduction block inside, which we can reduce, increase, and what is that something that you use? So because do you use a lot of contoured seat cushions to control that area, or are you using a flip up, flip down, excuse me, removable pommel at times? And the next question is, if we are going with the wind sweeping, or we're not using a pommel as such, a block, with people who have spasticity, if they engage, get excited, frustrated, upset, you often find that they're positioned like us, like anyone without spasticity. They will contract, they will bring their knees together, or they will bring them out, dependent, but most likely they will bring them together when they're getting upset, anxious, funny, it's showing emotion. And we may not always want that to be the case, although we don't want to restrain, of course. So there'll be times where we're like, yeah. How would you manage that situation?
Well, I'm going to start by the end, because I don't know if I remember correctly the first one. So
Sorry.
I'm going to start with the second one. No, sorry. And well, it's interesting. It's very interesting, this question, because sometimes it's like, I don't know, if you have assessed a tightened hamstrings, but the user have an extensor thrust, no, and or this dystonia, no, the dystonic movements. And how do you decide, no, what's the best solution for this kind of users, that they need this movement or they are avoiding? Obviously, if we understand, again, biomechanics and the muscles, we know that extensors are powerful than flexors, are more powerful than flexors. So what normally we try to do is to close that angle, because you are going to give more mechanical advantage to that flexors to avoid that hip extension. But what happened if the hamstrings are tightened? You have a big problem, because you are putting in more problems with the hamstring tightened, so they are going to have more posterior tilt, and it would be like the opposite things that you need. No, I think the best option in these cases, but in Spain it doesn't exist that solutions or are very expensive for that, is this kind of systems that going with you, this kind of sitting units that goes with you when you have this extensor thrust and comes with you when.
So dynamic seating,
Yeah, but
Ruben.
I've seen different systems of dynamic systems. I've seen systems just with a spring in the backrest.
Yep.
And I've seen other systems where the seat goes after the user. And I think that's much more interesting. All of them are interesting, obviously.
Yep.
But I think that's much more interesting because one of the problem when one user make this extensor thrust is that they lost their posture. And when they come back to their position, they are not well positioned again. So I think these kind of sitting systems help them to go with their movement and going back, and help them to express their emotions sometimes and going back. And you are not tightening more the hamstrings. So in these cases, I think it would be interesting, something like this. But sometimes it's not easy to get. Normally it's quite expensive. And in a country like mine, which is not reimbursed, it makes the things quite difficult. And the second question, or the first one, I think it was related about how do you do it if you use contour cushions or not. For example, I've been working with the distribution of specs products for 7 years, and I love that kind of products. But
other cushions are available.
Yeah, all the cushions, obviously, all the cushions that you can imagine. Well, J, Vicar, whatever.
Yeah, of course.
I was talking about that because my experience, and it's a good example on a contour cushion, no?
Yeah, I'm joking.
But obviously, it matters if for example, I have said that the research says in spastic cerebral palsy, not all of them are spastic. Not all of them are gross motor 4 and 5. And not all of them are people with cerebral palsy. So maybe you need to consider in every case what's the real solution for this unique case. And obviously, I rather a contour cushion which is soft and let you get in, that a pommel which is too hard and it's like it gives you the input to push harder, no? Even when you have some neurological condition. So I would tell you that the most important thing is to consider in every case, but I think that I love this kind of contour cushions when they need it, and I have used it a lot. And sometimes I have used other products that led me to respect the windswept, or other times I try to use something more flat, and I try to do with, I don't know, for example, the leg harness of Body Point, for example, when you can pull to abduction, or you can try to pull one more from one side and try to get this abduction and external rotation. For me, it's one of the best options to control abduction and external rotation. So I think it would depend. It's going to depend in every case. But obviously, when we talk about wind sweeping, and wind sweeping is very related with hip luxation, we should talk about how they sleep. Because how they sleep is going to be very related with this wind sweep normally.
I think
100%.
I think the topic of sleep is a whole another one. We should probably do another one on, I guess, sleep and things like that. But yeah, I think that in terms of what you said then around like pommels versus contoured cushions, you're right. It is. I would tend to agree with you that contoured can be a lot better. It is tricky. And what you mentioned, when they have a really high tone and maybe the contoured cushion isn't enough, but then if they do have a really high tone, then a pommel could make it worse because then they could dislocate their hips out. And this is where I think cushions like you mentioned like the Specs Constructor cushion, ones that really help guide the whole thigh, the whole way through to reduce that leverage point at the end of the knee, could be a really good option for some users. provided, it's not too difficult to get out of the way, and, the benefits of having a pommel that's removable if someone's doing a side transfer. Because I think about the last, like, as you were saying that, I was thinking of the last client I had who had a pommel, who had spina bifida, and then he had the ability to do a side transfer. So having a pommel that was removable was really important to him for that reason, even though he still had quite a bit of internal rotation. So for those imagining this, like picture one of your ankles going in towards your body, whilst the pommel was helping with, like, he had one leg that was a bit windswept. So say his left leg was coming in towards his body too much and his right leg was rotating. We still went with a pommel for that reason, because it was something that was removable. So exactly what you said, Ruben, in terms of like taking each case for what it is, because sometimes it could be good, sometimes it couldn't be, but this is what clinical judgment is all about.
Yes, but you have said something very interesting, no? That it's, well, we are considering just in an ideal user, which we are not considering the environment, we are not considering what they needed at home. And sometimes you need to mix these physical things with, he make the transfers independently, and it would be a problem, so, no? And we need a removable, so obviously we need to consider all these physical things that we have been talking about with all the daily life activities and how they mix with. So we have a very difficult work. That's the resume, I think.
Absolutely. I try to actually, I was even getting a haircut today, and he's asking me what I do for a living. And then when you say, like, I make bespoke wheelchairs, like, oh, is that like for, like, they just think like design, like people don't even think about like what is a bespoke wheelchair, and you're like, oh, there's so much to it, and you don't realize until you actually get into it that bespoke doesn't mean a good paint job or spinner wheels. There's a lot to do it based on people's function and all that. I think that's a good place to end it there, but I do want to have like some summarizing points for the guests listening at home that we discussed. So I think the first thing we touched on was the MAT assessment, and you feel the MAT assessment is really important because you're not so much a man of faith, as you said, you're a man of science. And clothes can lie to you, clients can lie to you, but what doesn't lie to you is the ability to assess someone in their body. I think then we touched on hip positioning, which is really interesting because whilst our goal is to get like a nice symmetrical, neutral posture for people, particularly in children, it is ideal to have some sort of abduction. And I think we're all still a bit, I'm not sure what the answer is in terms of seated abduction, in terms of how much you need to be, how important is seated abduction to reduce that hip dislocation. And it's a message I'll probably keep asking a lot of guests because it comes up a lot. And I know I was talking to my rep from Medifab about it because, I've got a hip surgeon that loves his children post-surgery in a lot of abduction. And sometimes I hear it's 12 weeks of abduction. Sometimes I hear it's 5 years. Like I've got clients that they're on their second wheelchair and they've got their leg rest swapped around the other sides because they're in that much abduction. So I still think it makes me feel better that someone like you, Ruben, who watches all the science and looking at everything, still isn't clear on the benefits of that much abduction in seating. And maybe it's something we can all learn together as to how beneficial is it. But you're right, there is definitely the practical aspect of sitting in a lot of abduction. It's not very practical for a lot of kids.
When I've read about these kind of things, the problem is that when someone does a research, they need to decide what's going to be the angle that we are going to try, no? So probably I've seen sometimes that they talk about 60 degrees of abduction, and it has worked. But the problem sometimes is who's going to be the tolerance of the user? And I have seen other research that they talk about the maximum tolerance of the user. So the research, I'm a man of science, but I always try to deal with science with carefully, no? Because what do you want? To get 60 degrees of abduction or to get 60 degrees of abduction for 2 hours or 30 degrees of abduction for 8 hours? I think that would be a good question, and it doesn't appear in the research, no?
Maybe,
so I invite the listener.
maybe something for, well, if anyone's listening, maybe they can know, but it is something I really want to know about, because I do see a lot of children with cerebral palsy or, some sort of congenital condition where, yeah, it's interesting. It's interesting to see what's the benefit of it? Is it even worth it? And I really did appreciate the end of this conversation about the differences between pommel and contoured cushions. I've always preferred contoured cushions myself as well. I just think they're easier to maintain. They provide external and internal rotation, or they guide internal and external rotation based off what you want. But yeah, in terms of doing side transfers or managing it, even doing standing transfers isn't always practical. But that's just the joy of what we do. We get to decide what's right for each client. And there are manufacturers that do custom things. I did a custom cushion not long ago that was like an extra tall pommel for her, because she had her knees were coming out and they were sort of getting up of the standard contours, but she didn't need really high contours on the side. It was just going in. So we did like one that was like extra tall. But that's the joys of what we do. I think if we understand the pros and cons of every option that's out there, that helps us make informed decisions for our clients.
I think that's so great. And actually, I think, Rubén, if you're open to it, we'd love to have you back on. And I think next time, let's talk about different presentations and how we would physically correct that. Let's go into the more practical side of things to help the listeners and the users understand why we do things and how we do things. I think that's really important.
Studies are always fun. If we can get some consent from clients, from all of us, maybe all three of us can have a hunt for some really complex postures, get some case studies, and we should talk about that for those who are able to watch the YouTube video.
Yeah, and we'll get a hip surgeon on as well. Let's put them to the test.
Yeah, we should get the doctor down here. He's named Dr. Axe, which sounds like Dr. Axe, which is like, what a cool name for a surgeon, like Dr. Axe. It's like for an orthopedic surgeon just to be like, I'm Dr. Axe.
Oh, that'd be quite funny. But yeah, no, listen, Rubén, it's been an absolute pleasure. Thank you for making the time with us this morning. I really appreciate it. I've learned loads. I've also confirmed quite a lot in my head while we're chatting. So yeah, it's been just great. I'm sure everybody listening, watching has really benefited as well. So thank you so much. Justin, have a wonderful day.
I will do. Thank you again, Rubén.
Well, I would love to thank you for inviting me to this podcast. Thank you for considering me, even with my English, which I think it's incredible.
Mate, first of all, bravo to Rubén, mate. Imagine having to explain all these complex topics and translating in real time. I don't know how you do it. I bet if this is all in Spanish, it'd be even better. But you've done a fantastic job to do it in English.
Well,
but I fully appreciate the difficulty.
Amazing.
Well, it is difficult. But thank you again, Rubén.
Thank you.
Guys,
for me.
No, thank you, Rubén. Sorry. Listen, everyone. Thanks for this. You've been listening to Wheel Chat. If you've enjoyed it, please click like and subscribe. It's very important for us to get your feedback. If you want to send us any messages, questions also, please feel free to do so, and we will help in the next chapter. Justin, that leads us to say just thank you so much. Have a wonderful rest of the week. I'm sure we'll catch up. Anything you want to close with and say hi to our wonderful users?
I just want to tell everyone that we'll chat to you next week. We'll chat to you next week.
Okay, so from Rubén, Justin, and myself, thanks for listening to Wheel Chat, and we'll speak to you again soon. Take care, guys.
Awesome. Thanks, guys.